Welcome to the Wow MD podcast, where in each episode you will get in 30 minutes or less valuable pearls about holistic wellness, anti-aging, hormone therapies, beauty trends, and other facts you should know about our medical healthcare system and your health that no one is telling you. My name is Dr. Mirala Cernăianu. I am a conventional board-certified OBGYN physician who, after the loss of my father due to a careless and uncaring medical team, decided to retrain and seek certification in anti-aging and restorative therapies. What I know, I am happy to share with you. Welcome back to part 2 of a small series of about 3 parts that's going to talk about lichen sclerosus. Last week, I described the symptoms and I explained what lichen sclerosus is, and I hinted that this week we'll talk about treatment options. Any of the treatment options, which I will discuss in today's episode, can apply to many unmanageable, difficult to treat, and chronic vulvar skin conditions. A lot of the technologies or therapies I will discuss are well known. Some of them, actually most of them, are not known to the average conventional medicine practicing OBGYN and will be completely unknown to your mid-level providers. So if you're under the care of a nurse practitioner or physician assistant, they do not have the know-how, the expertise, or the training to treat this condition. So let me discuss what would the treatment plan look like. What are the options if someone is suffering from a chronic inflammatory, possibly autoimmune skin condition, which has the unfortunate potential for scarring the vaginal skin at the entrance of the vaginal canal. And this doesn't necessarily pertain to lichen sclerosus. It pertains to many other conditions like lichen planus or other issues that happen to women when they give birth, but is specific to lichen sclerosus. Number 1, the only recommended and approved standard of care solution for lichen sclerosus is actually a topical steroid. And this is what you're going to get if you are seeing a conventional medicine-trained OBGYN. That means the local application of a steroid in the form of an ointment or a cream. And just FYI, an ointment is actually preferred for the vaginal skin because it allows better absorption of the medication in general. The topical steroid is either clobetasol, which is a very high potency or super potent steroid, or my preference, triamcinolone, which is a medium potency steroid. Now, if the woman has a lot of burning and itching, a high potency steroid might be well tolerated. But from my experience, a medium potency steroid like triamcinolone, 0.05%, works better, and it has less side effects than the most potent steroid, clobetasol, which is unfortunately the recommended first-line therapy for all women with lichen sclerosus. And triamcinolone is just as effective. I found that women have less irritation, less burning, or none at all with the triamcinolone. And the main problem with the chronic use of a potent steroid like clobetasol, maybe not so much with triamcinolone, probably less likely, is the possibility of secondary side effects, of which the top one is thinning of the skin. So chronic steroid use will lead to a thinner skin down there, which can be pretty significant, especially when the skin is already thin due to the actual disease process of lichen sclerosus. Now, I have personally found a steroid to be beneficial only in women who have symptoms of itching and white plaque formation. Otherwise, the steroid is not very helpful in reversing the course of disease, which is most of the time constantly progressing, sometimes more, sometimes less. There could be remission phases. And the steroid is not very helpful in improving any of the symptoms that really meaningfully impact women, like the dryness, the elasticity of the skin. These are the 2 main reasons why sex is uncomfortable or downright painful, and the steroid will do nothing to treat those 2 things. So remember, in case your doctor prescribes clobetasol, that topical steroids are first-line standard medical care therapy for lichen sclerosus. Other than the downside of irritation, burning, and the considerable risk of skin thinning with chronic use, the use of topical steroids as far as efficacy is limited in the sense that the condition can continue to progress as soon as the treatment is stopped. So combining a topical steroid with another method of treatment works a lot better because you can maintain the benefits achieved from a combination of treatments and just use the steroid once or twice a week to maintain and keep the inflammatory process of the lichen sclerosus in check. Because as we know, steroids are one of the most potent anti-inflammatory drugs that we have at our availability. So I'm not dissing the steroid use. They have a very important role in managing this chronic inflammatory condition because they're such a potent anti-inflammatory agent. What about number 2? Well, number 2 on my list, which I rarely use because of insurance coverage issues, because of cost and expense, and because I found that women have some side effects from it. But the next possible treatment who suffer from symptomatic lichen sclerosus with the burning and the itching and the white plaque formation, especially when that's not responding to steroids, would be topical Tacrolimus. Topical Tacrolimus can be used 1 to 2 times a day, and it's applied to the area of the lichen sclerosus involvement. It can reduce inflammation, it can reduce or eliminate the pain due to the condition, and it can improve the quality of the tissues. Now, what is it and why does it actually work? Well, Tacrolimus is a potent immunosuppressant medication that's used to reduce the body's immune system activity. It belongs to a class of drugs called calcineurin inhibitors. What does it actually do? Well, it inhibits our immune T cells. These are our key immune cells responsible for identifying and attacking foreign material like a transplant organ. That's why it's an immunosuppressant. Or an inflamed skin cell like in eczema or lichen sclerosus. Tacrolimus does help decrease the inflammation, the redness, the itching, and the burning associated with the skin condition. It's usually reserved for specific skin conditions that have failed to respond to topical steroid therapy or oral steroid therapy, like severe eczema. And it's only intended for short-term therapy. Now, most of the time, Tacrolimus can be compounded in an ointment for the vulvar skin application. Ideally, it would be used for about minimum 12 to 16 weeks and then monitored closely. And after maximum 6 months of therapy, it should be stopped. There are some changes in the body with systemic Tacrolimus. Blood pressure, blood count, blood chemistry should be monitored monthly or every 3 months, depending on how old the patient is, and depending on whether or not there are other chronic coexistent conditions that could impact these organs that could also be affected by Tacrolimus use. Again, it's a very potent immunosuppressant. It's used widely to prevent rejection of transplants for liver, kidney, and heart transplants since 1980s. However, it is considered very safe for topical applications, especially for small surface areas in which our vulvar skin is. It's a very small area with minimal absorption and a minimal increase in blood concentration after it's applied down there. Now, many studies that are done on the Tacrolimus absorption with the topical application for very small areas longer term report undetectable levels in at least 5 out of 6 patients. So pretty much in everybody. Now, most insurance companies should cover Tacrolimus like they do steroid therapy, but no pun intended, but insurance companies don't like to cover anything nowadays. However, because Tacrolimus is significantly more expensive than a steroid, it might be subject to more restrictions, it might require prior authorization, and is frequently subject to denial. Now, studies have shown that patients can be symptom-free, all as far as 1 year after the use of Tacrolimus is discontinued, as far as the redness, the inflammatory, the itchy, and the plaque formation capacity of lichen sclerosus. And maybe the skin of the vaginal canal entrance can improve, allowing for more comfortable intimacy. The jury's still out on that. It's very clear that the pain, the discomfort with spontaneous natural things caused by the itching, burning, and inflammation will get better. They don't really look at the whole sexual dysfunction problem caused by lichen sclerosus when they analyze these markers. So I couldn't find that data. Now, let me go on and talk about some unconventional options that are well known and work really well, and some that are less well known that you might just hear first on this podcast. What's number 3? What else can a woman do? Well, the most powerful weapon is actually estrogen. A little bit of topical estrogen applied directly to the area of the lichen sclerosus will improve the quality of the skin impacted by this condition. It can improve dryness and the loss of elasticity, improving the number 1 symptom women experience, which is painful sex. Now, remember, I told you this is a scarring condition. If you have a scar, very thin area in any part of your body, let's think about the face. And all the treatment that you're going to do to this scar is going to be applying a cream to it every day. How long do you think it will take in order for your symptoms caused by the scar to improve, or the appearance of the scar to improve? Well, it depends, but you're probably talking 6 months or more, maybe a year. Now, most women and couples in general will likely give up or try other things if they have to wait 6 months to 2 years for the loss of elasticity caused by the scarring of the lichen sclerosus to improve and allow them to have normal intimacy that's actually enjoyable. No one wants to wait 6 months to 2 years. Many simply give up. Now, applying topical estrogen allows exposure to estrogen only for a matter of hours to that skin. The area involved with the chronic inflammatory changes caused by the lichen sclerosus will, unfortunately, require constant, persistent, and steady estrogen exposure 24 hours a day, 7 days a week, 30 days a month. You know where I'm heading with this, right? Because I've talked about this in the past, and I've talked about the matter of bioavailability many times on this podcast. In my experience in the past 12 to 14 years, I can comfortably say I've diagnosed probably over 100 patients with lichen sclerosus. What I found to be extremely useful to the point of completely restoring normal and enjoyable intimacy within as little as 4 to 6 weeks, maximum 2 months, is none other than systemic estrogen in the form of pellet therapy. And here's why. No patches of estrogen applied 2 times a week. No estradiol gel applied daily. And no bioidentical compound skin creams will get you that effect that fast. Why? Well, because very simply, estrogen pellet, once inserted, is able to deliver estrogen in a unique manner and provide constant, steady levels in your bloodstream that never dip below an effective therapeutic level. So what is that effective therapeutic level? Well, it could vary from woman to woman, but I presume that it's probably somewhere between 80 and 100. Now, the estrogen patch applied 2 times a week, the daily estrogen gel, the daily bioidentical cream, when you monitor levels, they all dip down to 0 or whatever low the estrogen was before using that type of estrogen therapy at the end of the application of that therapy. So, for example, in 2.5 to 3 days after the patch, you will be back to where you started. You get estrogen exposure about 50% of the time of the 2.5 to 3 days. In 12 to 24 hours after a daily cream application or after oral micronized hormones, be it estrogen, progesterone, testosterone, doesn't matter, you are back to where you started, to no hormone. You get just about 8 hours, maybe even less in some patients, because absorption from the skin could be highly variable when you use a daily estrogen, a cream or a gel. The delicate and very sensitive tissue of the vaginal skin at the vaginal canal entrance, the vulva, requires constant estrogen exposure, like it used to receive from the ages of 12 until menopause. Especially if you're trying to heal something. You don't want to give it estrogen for a few hours and then take it away. You want to give it estrogen 24/7, 7 days a week, 30 days a month for months in a row, 3 to 4 months, because you know that nothing else is going to do that. Now, if a woman is to have good moisture and good elasticity of the skin at the vaginal canal entrance, she really cannot have estrogen on and off or receive help in nourishing the tissue 30 to 50% of the time. And also consider the fact that the dosing of the hormone replacement therapy method that woman has chosen, be it the patch or the cream or the gel, is rarely the highest level available, right? Most of the time, it's the medium level or the one above the medium level. That will impact how much estrogen is available to nourish and rejuvenate the skin of the delicate tissues down there that's already being scarred and inflamed and affected by lichen sclerosus. Think about the fact that many women in perimenopause are dealing with loss of desire and loss of lubrication during intercourse in their 40s because their estrogen has declined and they probably have very low testosterone and absent or very low progesterone. And many women on hormone therapy after menopause do not achieve levels anywhere close to what their estradiol used to be during perimenopause. So if you think you're going to get your estrogen back to where it was in your 40s when you're treated, that's not going to happen. So let me explain this in a simpler way, and that's what's important for women to understand, that treating lichen sclerosus with estrogen, it's not just sticking a patch on. It's not just using a daily cream. What type of estrogen you use matters. So let me explain. If your estrogen after menopause is 0, again, that's not always the case because most women do have a little bit of estrogen and their baseline estrogen is anywhere from 15 to 30. But let's say your baseline is 15. Imagine you use a patch. The patch has 5 available doses. The medium dose patch, the 0.05, applied twice a week, delivers at the peak of its release 50 above your baseline. So now your estrogen will go on upward from baseline to maximum 65 if your estrogen was 15, and then down slope again, back to baseline. So in 3 days, when you need your new patch, you're back down to 0. If your patch is 0.05, you go up from 15 to maximum 90, then go back down again. So when your next patch is ready to be applied, you're back to 15. Again, 100 is probably an optimal estrogen level where most women would see a significant improvement in the quality of their tissues, which will be able to restore the moisture and the elasticity. However, ideally, it would be a steady, persistent level of 100, at least for a few months, sustained. Whether it's 3 months or 6 months, it's hard to say. It depends from case to case. Now, even with a pellet, it will have some variations, maybe 20 to 30 below and above baseline, but the baseline should be 100, not 0, which is what happens if you use any other method except for the pellet. Yes, there will be some variability of the hormone levels with pellet therapy, but again, that variability depends on the ability of your immune system to vascularize and break down the pellet. It will depend on the heart rate, because if your heart rate beats faster, you release a little bit more hormone. If your heartbeat is slow and steady, you will release a lesser amount of hormone, which is different from patient to patient. Should there be some scar tissue in the area of pellet insertion, making the arrival of new blood vessel formation slow, it will also make the delivery of immune system cells slow, which will impair and decrease the rate at which your body is capable of breaking down your pellet in order to release the hormone from it. Now, for all the naysayers of pellet therapy, I only have 3 words. Nothing is perfect. And unfortunately, the FDA-approved products for estrogen therapy on the market and the bioidentical compounded products on the market are much worse in terms of bioavailability than the pellet therapy. With the pellet therapy, we are as close to natural delivery in a 24-hour window as we could get compared to the normal ovarian function. No FDA-approved hormone therapy in existence can claim a steady 24-hour delivery of estrogen. Unfortunately, you will need that type of delivery and that type of biological availability of circulating estrogen capable of improving, moisturizing, and helping the elasticity in order for lichen sclerosus to be meaningfully improved so that the woman can actually enjoy the sexual penetration. So in conclusion, estrogen with systemic delivery, not topical, will be unsurpassed in its ability to help soften, moisturize, and improve the elasticity of the vaginal skin at the entrance of the vaginal canal, which is unfortunately the limiting factor and what makes sex painful for a woman with lichen sclerosus. So we have steroids, we have tacrolimus, and we have estrogen so far. What else can we do? Let's say the woman is a breast cancer survivor and she's paranoid about not ever using estrogen. So should she be stuck? No. Number 4 on my list is testosterone. As you might have heard, testosterone is the most powerful anabolic hormone in the human body that goes for women as well as men. Anabolic hormones are hormones with the power to heal, restore, and improve the stamina, the strength, and the endurance, not just the body in general, but of the skin. They do have a very important role in our skin quality, and hormone therapy with testosterone, believe it or not, can improve the aging of the skin. Testosterone has been demonstrated to help in making the skin stronger and improving its elasticity. Guess what? This will come in very handy for a woman who has lichen sclerosus, because this will antagonize the process of the thinning and the frequent tearing that tends to happen during vaginal intercourse in women with this condition. Now, obviously, there is very limited, if very close to zero, research in the effectiveness of testosterone therapy and in treating lichen sclerosus. It's purely observational. It's not well documented in case-controlled studies. I discussed why women's health research is underfunded and not a priority. Hopefully, this will change in the future. Now, there's a lot of concern, and I hear this a lot when I mention testosterone to women. And women are scared that testosterone therapy can lead to overdosing, which can cause major side effects like acne, mood fluctuations, hypertrophy of the clitoris, hoarseness in a woman's voice, excessive hair growth on the face, on the body, and hair loss on the scalp. It is true that these side effects can happen, but they're easily managed with either conventional medication like spironolactone or natural supplements like saw palmetto, crysine, and DIM, and by simply adjusting the testosterone dose. But here's another thing with testosterone therapy. When it's used in the form of topical testosterone, it's difficult. There are no FDA-approved formulations. Any testosterone therapy applied topically will have to be compounded by a compounding pharmacy. And there's some major downsides there because it will be costly. Currently, no insurance plans, including Medicare, will cover topical compounded testosterone. Many women believe that if you have a cream or an ointment applied topically to the vulva, it will not get absorbed. It's just for down there. Guess what? It's not just down there. It's absorbed. Where hormones are concerned, the skin of the vulva has the ability to absorb hormones, and it will absorb the testosterone. A daily application can and will lead to a surge in testosterone levels, and any surging of testosterone has the potential to convert to dihydrotestosterone, which is a more potent skin testosterone, with subsequent side effects like acne, excessive hair growth on the body, hair loss on the scalp, etc. Another problem with testosterone therapy for lichen sclerosus is the fact that there's no standard protocol or recommendation for what to do, what dose to use, who is a good candidate for lichen sclerosus. It is the Wild West out there. So you are relying on your provider's experience in the real world of treating patients to guide you into what is the best dose to start. Monitor your response to therapy closely, not just with photographs of the area impacted by lichen sclerosus, but also with questionnaires about how you feel and whether or not there are any clinical improvements and what kind of improvement do you feel. You always have to have a sexual dysfunction questionnaire. And monitoring the hormone levels, it's absolutely mandatory, and always ask for possible side effects. And if you feel something's happening and you're not sure if it's related to the testosterone or not, share it with your provider. He or she will love to hear it. Sometimes you hear some very strange things from patients and you don't think it's possible, but it is. We all have a very unique genetic imprint, and we respond to hormones in a very uniquely way. And when it comes to topical testosterone, women with lichen sclerosus have to be patient. It could take months, maybe 6 months, but there could be significant improvement of the quality of the skin, finally allowing at some point for normal, enjoyable intercourse. Some women with lichen sclerosus respond better to estrogen, and some women respond better to testosterone. And some women respond best if there's a combination of both estrogen and testosterone therapy of the tissues impacted by lichen sclerosus. So this episode got a lot longer than I thought. I have more options to talk to you about, like PRP, exosomes, and peptides. And I haven't even touched on lasers. So please join me next week as I continue this very informative discussion on lichen sclerosus therapies. As always, I am extremely grateful that you chimed in and are listening to what I have to say. Thank you for trusting me with your time, and thank you for listening to today's episode. If the content I provided wowed you, was helpful and valuable to either you or someone close to you, please do me a favor and leave me a review. I am very open and welcome any kind of feedback as well as suggestions on any content ideas, so please forward those suggestions to Jessica, my patient care coordinator, through our website, herabeautyandwellness.com. And I look forward to our time together next episode.